What's up, everybody? My name is Maggie Reichard, and you are listening to Nursing Uncharted, the podcast that introduces nurses to all different types of nursing. Thank you so much for tuning in and listening to us today. If you like what you hear, please let us know and leave a review on Apple Podcasts. And if you don't like what we hear, just keep on scrolling. Just kidding. Well, we hope that you like what you're listening to. And I like to tailor these episodes to what you want to listen to. So if you're interested in hearing about a particular topic, let me know. Send me a DM on Instagram at Nursing Uncharted and just let me know what you want to talk about or who you want us to talk to. So we are nearing the end of July when this episode airs, and I hope everybody is having a good summer so far on their days off, getting a little R&R. Summer is always a pivotal time in the inpatient setting because it's a time of new beginnings and fresh new recruits. We're talking about the interns are new grads are starting. So are you starting a new job? Are you a preceptor now? Are you dealing with new interns? Let me know. Do you want to hear more about that stuff? Let me know, guys. So today we are back into the thick of the inpatient realm. Oh, I also wanted to say, if you're watching on YouTube, you might see behind me that my backdrop is looking a little bare. I am moving. I've been building a house with my husband. Well, physically, not me building the house, but we've been building a house since October, and it's finally ready. And so we're closing on Friday. So our house is a mess. And I think after this episode, I'll probably be set up in some new digs. So that will be exciting. Backdrop will look a little different from here on out. So today we're going back into the inpatient realm. We're kind of going back into the thick of inpatient, into a specialty in ICU nursing. We're talking about surgical and trauma ICU nursing today. So here to delve into this realm of nursing with me is Liz Christian. Liz has been a trauma surgery nurse for 6 years at a rural level 1 trauma center in New Hampshire. Liz started med-surg first and worked her way into the ICU after about 2.5 years. Liz also has kind of a unique specialty within the ICU nursing realm too, working sometimes as a tele-ICU nurse, which we'll talk about later. She also became CCRN, the Certified Critical Care Nurse, last year. When not in the ICU, Liz can be found cooking, reading, and playing with her 4-month-old kitten, Mojo.
Hi.
So Liz, welcome to the show.
Thank you for having me. This is really fun.
Yeah, absolutely. I'm glad that you could come on. I met Liz at NTI a couple months ago.
Yeah,
I can't
believe it. I'm still kind of riding the, I sent a unit email of all the cool stuff we saw, and I was like, I'm still riding the high of, like all the enthusiasm and the passion. It was just really, really something special. So, and I met you and Raul and all of those amazing friends that we've made, and it was an exceptional experience.
Yeah, I would highly recommend anybody that wants to, start going to conferences. NTI is a great one to start with.
Totally.
There was like a good mix of kind of, emotion or like, feeding to our kind of reigniting passion, and also like the educational piece, like 2 in 1. It really built connection.
Well, we haven't been able to share information and experiences with each other in 3 years. That was the last NTI was in 2019. So it was nice to be able to, have those connections and network and share our COVID experiences. And I think the Rooted in Strength theme really spoke to that, how we have just overcome incredible obstacles in nursing, especially managing critically ill COVID patients. It's just, and we wouldn't have been able to do it unless we were sharing info with each other and figuring out what worked and what didn't. And so I think it was nice.
Yeah.
It was nice.
We don't really allot ourselves enough. In a sense, I feel like I'm kind of enveloped in nursing culture. Like I'm on nursing Instagram memes all the time. Like I'm, like there's like relatable content coming in and out all the time, but it's different if you are all coming together in person and like talking about your actual experiences. That's something that we don't. And even at work, I mean, we don't take the time to like, you know, really delve into that stuff and talk about
where's
that
the
stuff.
time?
So it was a,
you know,
right.
often
Yeah.
it's you know, okay, wow, that was really terrible, and we're gonna shake it off, and we're just gonna kind of keep trucking until 7 a.m. and hope that, you know, nothing else hits us on the way there. It's so, and then, you know, at the end of the day, you don't want to, you just want to go home. You know, there's not really a chance to talk and decompress and debrief, really. So, yeah, I found that NTI, that experience was very cathartic, being able to talk about, you know, kind of what we've all been through and what we're doing. You know, what are you doing in the SICU there? And what are you doing in the MICU there? And how are you managing those patients? And, you know, so that was, I had a lot of folks approach me, especially those that are in surgical ICUs, very small surgical ICUs, and you know, how are you managing patients with open bellies, which we'll talk about, and you know, how are you managing patients after X, Y, or Z trauma? And so that was really interesting. You know, the standard of care is kind of a blanket, but the way surgeons practice is different everywhere. So you know, and that affects how us nurses kind of manage and practice as well. So that was interesting.
Yeah, absolutely. It is, you do leave conferences like that with a broader understanding of where you're, how you practice, and you know, you come out with ideas to bring to your other hospitals. Like, hey, they're doing this over here. Like, why can't we do that too?
Yeah, totally.
You know. So let's get into STICU. So what really, you started in med-surg.
I started in med-surg.
What really led you into STICU
nursing?
Nursing?
You know, taking it way back, my parents were actually volunteer EMTs when I was a kid. And, you know, I would go with them. We would be in the car and they would get a call and we would just go. And, so when I first, I know,
so cool. You're like
I was
a little,
like, I can remember being in a booster seat and my mom being like, stay in the car, and having, you know, one of her EMS friends sitting with me while she went into the house. And it was just like, it was a really wild experience. But I found myself initially with a passion for emergency medicine. And when I finished nursing school, I didn't have the clinical experience to start in the ED. So my recruiter at the time was like, I'm really sorry, but we can't put you in an ED with the clinical experience you have. So why don't you start on this trauma med-surg floor? And, you know, it was orthopedic and trauma surgery. So we did motor vehicle accidents, but we also did hip and knee replacements. And it was a great, you know, setting. I never valued the start in med-surg until I actually did. And you learn so many skills and your time management and, you know, recognizing patient condition, changes in patient condition. And so I started there, and I loved the patient population, the TBIs, and, you know, the ortho trauma. And then, you know, your patient starts to decompensate and you start to get like into the thick of it. And then all of a sudden they're getting whisked away to the ICU. And it was like, well, wait a minute. I was just starting to learn.
I want to see that
through.
That's
my patient. Where are you going? I want to know what happens from here. Like, so that's kind of where I finally was like, all right, I need to go there. Like, I need to be where they're going, because I kind of want to, like you said, I want to see this through. So that kind of was my bridge to the ICU. Was I finally had kind of hit my max of what I could learn and what I could see in med-surg, and I wanted more. I was just hungry for more knowledge, and I was hungry for more skills, and I wanted sicker patients. And so I just jumped right in head first.
I think that that's a good, I mean, we kind of started in the same way in that I started in med surg too. I was on a neurosurgical, and our sister unit was that unit. It was like the trauma orthopedic unit. But we got like a lot of back surgeries and the TBIs and but there is a really, I mean, I think it's not, I wouldn't say you have to start in med surg, but it does give you so many tools, the prioritization piece. Oh my God. So, I mean, I can't imagine if I started just focusing on one or two patients, I would have never been able to expand and focus on 4 or 5 or 6, I think that was like such an important piece.
And I find assessment skills, just basic assessment skills. I mean, and when you're in med surg, you're learning to do focused assessments on 5 patients, and then or full head to toes on 5 patients. And then when you get to the ICU, you're able to manage assessments on 2 patients. Even if they, even though they are critically ill, okay, you have a couple more lines that you have to assess, and you've got more drips, obviously, to manage. But ultimately, the patient that's laying in the bed is the same. You're gonna assess their neuro status. You're gonna assess their cardiopulmonary status. You're gonna assess all of that stuff as if you would in med surg. It's just a little more, intense.
Little more, maybe things are a little more wrong, but actually, like when you're documenting, the time it takes to, document a full assessment, that's the same. I mean, the flow sheet is the same in acute care versus ICU. It's just more, I mean, so that's just another part of the prioritization piece and time management piece is, you have the same assessment per se in an ICU versus acute care, but in acute care, you have 4 or 5 people to do them on. So, and if you're trying to be thorough, you're really looking at all of those systems and pieces.
Total. Yep.
For all your
absolutely.
people.
And I also find, so we do orient new grads to our ICU, which is great. We usually require that they do like a practicum or that they have had some kind of ICU clinical experience. I find that they're excellent. These new grads, they're smart and they're eager and they kind of already know the culture and the acuity. They kind of get that. But I do find that, it's hard to teach somebody to be a nurse and also an ICU nurse at the same time, because I do find that they are a little different. So you're trying to teach this new grad to do their assessments and to do, just their basic skills and their time management and their prioritization. And then on top of it, you're teaching them to manage drips, and you're teaching them to manage lines and helping, assisting in procedures. There's a lot more that goes into being bedside in the ICU than in acute care.
Yeah. I think that also goes, I'm going to be a preceptor soon for this new batch of new grads. And it's a good thing to point out to kind of remember where you came from, because I think when nurses that started in the ICU, they probably have a better perspective on starting as a new grad in the ICU versus me. I did med surg for 8 years. So it feels like a little more, they're not going to have the time, or, the acuity is not, low enough to the point where we can slow down and like focus on this, like, time management piece. But I guess that's not necessarily, super important. I mean, people end up doing it, if you just roll with the punches, and whoever your patients are that day, they are that day.
I find it's the nurse too, the new nurse, and like the dynamic between the preceptor and the nurse really can make or break that, the new grad experience. And I always find, and I hate to say it, but the ICU, sometimes your orientation is trial by fire, because you just you just never know what's going to happen to your patient. You know, one minute they're sitting there hanging out and talking to you, and the next thing you know, they're bleeding or they are decompensating, and you're like, wait a minute, you know?
Yeah.
So
Like, ooh.
yeah, and it happens on a dime. And so really preparing a new nurse for that, you know, because there's a comfort in stability, right? We find that our patients are stable and we're like, whew, all right, they're out of the woods. But, you know, in reality, they're in the ICU for a reason. So, yeah, I find that it's hard to sometimes orient those new grads when you're trial by fire orienting them. And then you're like, right now, we don't have time to talk about this, but I promise we'll go over it.
Yeah. I think like that's the piece that I'm going to struggle with in precepting for the first time in the ICU is making the time. You know, it's like you if you have to stay later to explain some piece, I think ultimately I'm going to end up choosing to stay later because it really will, you know, make them understand their experience more. You know, I mean, in acute care, you have that time to kind of sit and go through. Sometimes, I mean, low acuity wise, you may have the time to, like, you know, work through why the patient is here and stuff. Whereas you might not have all that time in the ICU, but you know, yeah, that's a piece I'm definitely going to have to work on.
Well, and in acute care too, you have the patient is here for this reason, and they're generally ready to either go out the door, they're waiting for placement for rehab, or they're waiting for something, and you know, so there, like you said, there is that time, and it's also very focused. I find that if I had somebody coming in for a knee replacement when I was in med surg, I focused on that person's knee. I focused on them, their mobility, their pain, and getting them home. In the ICU, it's multi-system, right? So you have to think there's a lot more pathophysiology where how are their lungs and their kidneys working to compensate for an acidosis, or, you know, how is their neurostatus and their neuro trauma, for example, how is that affecting their cardiopulmonary status? And so there's a lot more multi-system assessments in the ICU and multi-system management also. We love to put lines everywhere. And so we have to manage those, right? And when we take over those body systems, you know, we put a Foley catheter in, we got to manage that. We put a breathing tube in, we have to manage all of that. So it's a lot more complex when you think about your focused assessments in med surg and then your complex assessments in the ICU, and how those are ever evolving. You know, you're assessing your patient, I think, in the ICU, how many times a day? You know, if you're
just
constantly, especially if you're singled and you have a filter, or you have, you know, we're doing large volume resuscitation in trauma, and like you're at that bedside and you're assessing every 15 minutes, every 5 minutes. So there's a lot, and that can be very overwhelming as a new grad. I remember even being an experienced nurse coming from med surg, I was like, whoa, this is a lot. This is a lot. So it's a big learning curve.
It's doable. It's doable, you know?
It is.
But I should talk to a new grad going into the ICU about what their experience is. I know it's a lot, but I think that they would say, you know, I mean, I did it.
Yeah. So. And our new grads, we have been so fortunate. They just thrive, and they, you know, they really come into their own. It's really, you know, it's one thing to see, you know, a new grad on med surg, you know, they come into their own too. They get more confident, and you can see it. But in the ICU, it's like almost palpable when they put in a good line, when they have a good catch, you know, you can see they are so immensely proud of themselves, because these people can decompensate so quickly if you don't do that in a timely manner.
Yeah.
For example, I had a new grad who caught a gentleman who had a pneumothorax. Spontaneous. We were sitting there one night just chatting, and all of a sudden he desatted, and she was like, "Oh, that was kind of weird." And she put a stethoscope to his chest and said, I think he's got a pneumo. And, you know, he was on high PEEP therapy, and that stuff can happen. And she did.
Yeah.
We took a chest x-ray, and sure enough, it was very obvious. And it was one of those, like, you know, I was like, good job. That was an amazing catch. And she was like,
yeah,
you think so? Yes. And
that's what you're supposed to do. Put two and two together, not just assume, you know, that like it was a weird,
just a fluke. Blip. Yeah, exactly. Yeah. And her watching her confidence level after that night is just like, that is the most rewarding as a preceptor for sure.
Yeah. That is awesome, because I think that there's a switch eventually where, you know, new grads are focused on like task oriented things. Like, I just need to get through this list and through the day. And there's a switch where you kind of start to look at a little bit of the bigger picture, or you start to catch these like little assessment changes and be confident that it's not something that you just, you know, are, you know, picking up on, but maybe you didn't pick up on it before because you're a new grad. You know, it's like being comfortable in your ability to assess your patient well. And a lot of times I think new grads do more of a in-depth assessment because they don't know what they're looking for. So they have to be, you know, be confident in what you're assessing.
Be confident. You know, be thorough.
A lot of times,
be thorough.
Yeah.
So it was, I think you're going to be a great preceptor. You're going to love, it really is so rewarding. And I don't know what your culture is like on your unit, but for us, like, we orient kind of as a village, right? Like, yes, you have a primary preceptor, but you have a village behind you. You have your neighbors, and you have the resource nurse, and you have the charge, and, you know, during the day shift, you have your clinical nurse leader, and you have all these people, you know, our nurse educator, and all these people that are involved that want to see you succeed, that want to see new grads succeed, or anybody that's orienting to the ICU succeed. And so I always tell my new grads or my preceptees, like, we are here to set you up for success. If you want to be an ICU nurse, like, we are here to support you through that entire process, however long it takes. And, I mean, and it's one of those things, like, if you have a question, talk to somebody else. Everybody has a different perspective, right? Everybody has their own experiences and backgrounds. And, so it's kind of, I always say, phone a friend, survey the crowd, you know, see what other people have done or what they're doing. And then come up, you know, and then they get their own style. So that's,
absolutely.
It's fun.
It really is a village, I think, in the ICU. We'll be right back to our interview. Grab a cup of coffee, but don't go anywhere, because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show. Let's talk about more specific STICU stuff. So what is your patient population really in surgical trauma? Like, what are the main people that you see?
Sure, yeah. So we are primarily adults. So we do 18 to 101. We
and the cutoff.
That's it. Well, I think that's the oldest trauma patient I have seen.
Oh,
is
wow.
101.
Okay.
And you know, and trauma is one of the leading causes of injury in adults. And so we see anywhere from, I mean, You have your low-level motor vehicle accidents. They maybe have a small head bleed and they want them in the ICU for frequent neuro monitoring, just to make sure that the bleed doesn't get worse or they decompensate. So we, do those Q1 hour neuro assessments, keep them up all night, and they love us so much.
Right. What's your name?
Yeah.
What's your name?
Where are you?
With the pen light.
Where are you? What are you doing here?
God, it's so awful. But it's necessary.
It is. People
will change. But I know.
It's one of the I have seen those.
Imagine.
Yeah, and I've seen those. You go in that hour, it's 11 o'clock, you're talking to them, and then the next thing you know, you go in there and they can't move their right side and they've got a droop, and you're like, oh man, that's a bummer. Yep. Yeah.
That's a bummer. We gotta go to CT.
Oh, man, I hate it when that happens.
Yeah.
So we get orthopedic traumas. So we do external fixations and frequent neurovascular checks, so pulse checks. We do management of open abdomens. So if you have a motor vehicle accident, for example, and you sustain an abdominal injury, we do, your primary assessment is done in the ER. It's usually done in the trauma bay. And if you have any kind of abdominal injury or process, you go to the operating room. They do what's called damage control surgery. So they go in, they find either the source of bleeding, or maybe you have a hollow viscous injury. So you've got a ruptured bowel somewhere. They manage those, they stabilize them. They usually leave them open. So if you have any kind of leakage, any kind of bleeding, we usually like to keep people open so that we can do serial washouts, returns to the operating room.
Wow.
So we manage those patients. They usually come to us intubated, with breathing tubes and sedated. So that's one of our large volume resuscitation patients where they've lost crazy volume either in the OR or in the field. And so it's a lot of blood product. It's a lot of crystalloid and colloid resuscitation.
So how do you keep them open? Do you like clamps and stuff, or like still there?
Yeah, so usually they're packed. They're packed with pads, or packed with packing, and then our ICU manages with wound vacs. So we do Abthera wound vac therapy. So it's a sponge that kind of goes into their abdomen. We usually protect their viscera, and then we put the sponge on top, and then the vac therapy. But
so it's not completely. I was like, how do you keep that sterile? I feel like everybody would go into septic shock.
Yeah, no, and back in the day, here's one of those examples where every surgeon is still managing those patients differently. We have 4 trauma surgeons, and they manage their open abdomens differently.
Yeah.
And this is where I was talking to one of those low, small STICUs that's still managing with just sterile drape. They just take like that plastic drape and just stick it on their abdomen and send them to the unit. So
that would make me so nervous.
Yeah, and so that that's really how you, depending on how they're sent out to you, depends on how you manage them. So, for example, way back in the day before I started in STICU, we used to medically paralyze all of our open abdomens so that they didn't move, so that they didn't have that opportunity to cough and dehiss, or they didn't try to sit up and crunch their abdomen and dehiss or rupture. So we don't do that now. My ICU does not do that now. I have a trauma surgeon who loves to try to extubate his patients with open abdomens. But you have to think what comes with that: pain control. So we have a really hard time managing these people's pain because they have a massive open wound. And so
Yeah.
we always advocate against extubating patients with open abdomens, only because it's very challenging to control their pain without continuous narcotic infusions.
Yeah.
But
Right.
that's just, one of our surgeons that gets a little happy.
I can see the that's like one of the nuances about ICU is that you have the ability to kind of play with all of these different factors, and like like some people are just cowboys when it comes to
Oh
when it
yeah.
comes to doing things. Like, I mean, in one, I can see in one hand, yeah, intubation for longer periods of time for something that could potentially be managed while somebody is awake, or while somebody can protect their own air rate. I understand, the benefits to that, but also, so many other things come with, uncontrolled pain. You have like increase in catecholamines, you have like an inflammatory stress response. The patient is super uncomfortable,
Very
like moving
uncomfortable.
around, like the opportunity to de-iss. I'm sure like that's something, you just have to,
Yeah, it's a
that's
big
wild.
risk benefit. And a lot of times the surgeon finds that the risk of keeping them intubated is greater than the benefit, and
Yeah.
so we extubate. But it does present a challenge for nursing, because obviously we hate seeing our patients suffer, and there's
Right.
no reason for it, so it just it just becomes a challenge.
Yeah,
Um,
for sure.
and then so that is in the setting of trauma, but we also do, on the other side of it, we have like general surgery. We do ischemic bowel, so
Mm,
necrotic bowel, intestines that have had, thrombosed vasculature that, compromises that really viable or that really friable tissue that's really
yeah,
delicate. So we manage those patients also. We keep them open. That's large
yeah.
volume resuscitation, and then you have the risk of sepsis, especially in necrotic bowel
Yeah.
cases, big time.
For necrotic bowel, so in our ICU, necrotic bowel is almost like a surefire this patient is going to die. Like they get like their lactic levels freaking skyrocket, and their acidosis skyrockets, and then their pressors don't work, and then they just, I think like at that point, like if they get ischemic bowel, then it's like, all right. And because we can't whisk them away to the OR, a lot of times they're not surgical candidates. So I'm kind of curious, like, who is a surgical candidate for ischemic bowel? Because I feel like I've never had a patient that were like, okay, he like he is able to go to the OR. Let's take him now.
Yeah, I mean it's case by case, really,
Yeah.
because you do have to consider their comorbidities. What else is going on with these folks clinically? Is it just, and sometimes the ischemic bowel part's not their primary issue, right? Like they come in
Yeah.
and they develop ischemic bowel because
Right.
they were on a high pressure requirement, and we know that all of that blood flow gets diverted
Yeah.
from your mesentery to go everywhere else that's important, and yeah,
Yep.
you end up losing that bowel. And so I mean, we do not hesitate to whisk people away. We
Mm.
really don't, especially if they've come in for bowel surgery, or if they've come in for some kind of
Mm-hmm.
general surgery, and we notice evidence of ischemic bowel, we don't hesitate to reopen and do XLAPs,
Yeah.
just to
Okay.
just to see what's going on, especially in the setting of a rising lactate and a pressor requirement. If
Mm-hmm.
they get to a point where they're triple pressed, on three pressors, a surgeon may say, even
Yeah.
if we go in and take this bowel out, this is not reversible.
Right.
So yes, our threshold is low for managing and treating,
Mm-hmm.
but the threshold to actually, if Yeah. If their patient, if their condition is just beyond kind of repair,
Yeah.
then we do a goals of care conversation with the family and
Yeah.
kind of let them know what's going on and the trajectory of what we're seeing.
Mm-hmm. That's, yeah. A lot of times I think in our ICU, ischemic valve is a secondary thing that comes, and it's like, we don't have surgeons that have like put eyes on the bowel in the first place, or like have a, incision or something that they can like reevaluate and like open back up. Like a
Yep.
lot of the times it is because, maybe they had CPR 2 or 3 times and we were coding them for a long time, and they just
Sure.
have, their low blood volume to that area, just
Yeah. And
blocked off
you're,
circulation to that area for too long, or
yep. And sometimes, like I said, sometimes that's just an irreversible condition. And
mm-hmm.
that's really hard. It's really hard to be a bedside nurse and have a surgeon say, there's nothing we can do.
Yeah.
Because as a nurse, you know what that means. And you
Yeah.
know what that means for the family, you know what that means for your patient.
Mm-hmm.
So yeah, that can be a challenge for sure. But
Yeah. Do you feel like you have those conversations with patients, or do you feel like your teams are normally pretty good about having those with family?
oh boy, it really depends.
Yeah.
Our surgical team is really good about being quite frank,
Yeah.
especially if it's a trauma patient that comes in and we have access to their next of kin. We tell
Mm-hmm.
them we'll do everything we can, but this is a very serious and grave injury. This could be potentially fatal.
Yeah.
I always find now that I've, that I'm an older nurse, I find that I am more, I'm sorry, I'm less likely to sugarcoat
Yeah.
things. I present it very nicely, and I always tell family, I've seen this before, and they'll ask, and you have family
Mm-hmm.
that will ask you, have you
Yeah.
seen this before? Do you think they're going to die? And you've got
Yeah.
to, I think there's a very fine line that we walk there with that
Mm-hmm.
question. You know, we don't have a crystal ball, but in other cases that I've seen here, this may not be survivable for your loved
Yeah.
one.
Yeah. I think in those conversations the most important thing is to just be very transparent about what you know for that particular circumstance,
Right.
but also know, I mean, as a nurse, if I know for sure, I mean, if they're on 3 pressors and their lactic is raising and they're like acidotic and I can't get their maps above 65, I'm comfortable talking to the family
Yeah.
about, this is what I'm seeing and this is, but a lot of times I feel like our teams are pretty good about preparing families before it gets to that point. But in some, a lot of the gray area where, we're still doing interventions and like hoping that things will work. Families want to cling on to any,
Eh,
hope that they have. So
Totally.
you don't want to take that away from them, but you also just want to prepare them
Yep.
for what is probably inevitable.
Yep.
You
Yep.
know.
The reality, I always say, it, of course we want your loved one to get better, and we're doing everything we can, but I
Mm-hmm.
fear that despite everything that we're doing, that it may not be enough.
Yeah.
And I
Yeah.
think we definitely, I don't know if this is true for you, but I feel that we do not, just in general, we don't talk about death enough. And I find that in a
Mm-hmm.
surgical ICU, I mean, medical ICU too, we see a lot of irreversible conditions.
Mm-hmm.
Um, and so we become comfortable saying, this patient is likely going to die. And so just coming with that experience, being able to talk to family and saying, we've kind of reached the point where we're not really sure what else we can do. And
Yeah.
again, I find that a lot in surgical and trauma settings. They have, for example, recently we had a very severe ortho trauma case come in and brought him to the operating room, and they got him open, and they were like, there is just the extent of his internal vascular injuries were so severe that there was just nothing that they could do. And so they closed him up and brought him to the ICU, and then he passed. And they, told the family, like, we tried, we took him to surgery and we did everything we could. And unfortunately, it was just not in the cards.
Yeah.
So
yeah, I mean, there's a lot of times certainly for trauma, I can imagine, you don't know what you're getting into. You don't know until you open them up and take a look.
right.
So,
And then you have these devastating head injuries. So here in New Hampshire, we don't have a helmet law. So you're not required by law to wear a helmet on your motorcycle.
Oh.
And so we see these incredibly devastating head injuries, and they are often fatal, because it's just, you can fix a bone, you can throw a breathing tube in and you can manage somebody's lungs, but you can't get brain back. You can't get that back. And so that's, we see a lot of neurotrauma, a lot of neurotrauma.
Is neurotrauma managed differently than the other specialties?
No, not necessarily, but it is more collaborative. So we have our trauma surgeons, who are usually the primary team for those patients. They come in labeled as a trauma, and then they have neurosurgery consult. So usually neurosurgery will manage their neurologic injuries. Sometimes, depending, they'll manage their cervical spine injuries as well. And so that's where it kind of gets sticky, right? You have your primary team, and then you have the secondary team. And sometimes you have to report to the secondary team, so that you can get orders to manage that, mannitol, 3%, does this person need an extraventricular drain? Do they need a bolt to monitor intracranial pressures? So we are a very collaborative ICU, and we have to be, because these patients are so complex. We work closely with orthopedics with their ortho injuries, and we work with our anesthesiologists for pain control, and then we work with neurosurgery to manage their head injury. And so it's there's a lot of cooks in the kitchen.
Do you have a neuro ICU?
We do. Yep, we do.
Okay.
Yep.
That's because a lot of, our patients with like bolts and EVD drains and all of that, like ICP monitoring, they would all go to the neuro. But
see, for us, it depends on the setting. So in our trauma setting, if we put a bolt in or an EVD in, they come to the surgical ICU. If they have a hemorrhagic stroke and require an EVD, they go to our neuro ICU.
I see.
And so I am cross-trained in both. When I first started in the ICU, we were launching our neuro ICU, so they were cross-training all of the surgical ICU nurses to work down there. So we were getting trained in TPA administration and thrombectomy, post-thrombectomy management. And so we kind of learned a lot that way, which is nice. And we developed a really good relationship with our neurosurgery team that way. So again, that collaboration, and you have to all work together, because these patients are just so sick.
Man, I just gave TPA for the first time the other day.
Did you?
That is a scary med.
It's nerve-wracking. It is.
That is a scary. So TPA is the thrombolytic of choice when you have any clots anywhere. And I think this woman, I was floating around the ICU, and one of our new grads had the patient. And so she obviously was her first time, but it was my first time too. And so I printed out the policy. I was with the whole thing, got pharmacy involved. They were we had everything. But you have to do Q 15-minute neuro checks, what's your name?
Yeah. So
every 15 minutes for like 2 hours, and then every 30 minutes for another 2 hours
Oh yeah. So it's Q15 for 2, Q30 by 6, and it's Q1 for the rest of the 24 hours post TPA.
Yeah.
Yeah.
Wild.
And so for us, we only have certain nurses that can administer the actual medication, but we obviously can do the follow-up assessments and management. And then, you go for your follow-up head CT to make sure they don't have hemorrhagic conversion, which I've seen. And sometimes you see it. Sometimes you see it in the middle of the administration of the drug.
Yeah.
Which is scary, and which is super scary. Sometimes you see it, it'll be, you're at the 23rd hour and everything is looking good. And then all of a sudden they have a neuro change and you're like, oh, all right, guess we're going to CT early.
Yep. What are some of your favorite patients to take care of in the STICU?
Oh yeah. I'm a big open belly fan. I love high volume resuscitation. I love, they have these awful capillary leaks and they're weeping in their, internally, and we're replacing all of that. You have your fluid replacement resuscitation on top of your volume resuscitation. So it's a lot of giving albumin and giving LR, and you're constantly, like I said, you're constantly reassessing to make sure that they're not bleeding, and you're making sure that they don't develop abdominal compartment syndrome, which is a condition that can be fatal. The pressure in their belly gets to be so high that it starts putting pressure on the internal organs, and you lose that flow, and then your liver starts to fail, your kidneys start failing, and you lose your pressure because it starts putting pressure on your superior vena cava, and it's just the implications of abdominal surgery. The complications of abdominal surgery are far and extensive. So I really like managing those patients. It's just a lot of, I don't want to say fun, but it is.
It's tasky, and you are thinking about every system, and the question, what's your favorite patient, is always a funny thing to ask ICU nurses, because they're always the train wreck, worst,
the sickest of the sick. Yes.
And it doesn't, it's like we're so compartmentalized as far as like, it's not our favorite. We don't wish that on anyone, but this is like the job that we have been taught to do, and we can do it well. And these are like the high stakes, fast paced environment that put us in the ICU. So in that circumstance, they're our favorite patients to take care of versus people that we don't have to think as critically on, or we don't have to, use as many of our critical skills.
Right. That was why, and like I said, before, I went to the ICU because I wanted to follow the pathway of my sick patients.
Yeah. Right.
And so when you are, and I think when you are in a one-to-one assignment and you're managing a really sick patient, obviously it can go one of two ways. It can go well and they can stabilize, or it does not go well and you have to code them, or they end up expiring. And I think there's a lot of thrill in that line of, is my patient going to stabilize, or is my patient going to decompensate further?
Yeah.
And I think a lot of surgical trauma nurses, ICU nurses, are a little bit of adrenaline junkies. Like a lot of us do. A lot of us participate in high risk sports, which is really funny considering what we do for a living.
Like, when do you guys just sit and like drink tea and do yoga?
Yeah, never. It's like, it's like, yeah, I'm getting off shift. I'm going to go skiing. I'm going to go snowmobiling. We have people that ride their motorcycles into work. And so it's just, I'll never forget, I had a trauma surgeon. We were taking care of a gal who had gotten into a skiing accident, and she had been a skier her whole life, and she fell and sustained a head injury that was devastating. And I said to my trauma surgeon, I said, I'm going skiing this weekend. And he just kind of snapped and was like, how are you going to go skiing after managing this patient? Like, doesn't that make you nervous? And it's like, well, if we lived in such a way that every patient that walks through the door makes me nervous to live my life, I would never leave my house.
Yeah.
I would never get in a car. I would never walk down the street. We see pedestrians getting hit by cars. We see people driving to work or driving to the hospital to get their regular appointments, and they get into accidents. Anything can happen at any time. And a lot of us choose to live our life in such a way that we're going to enjoy it. And even that woman that we were taking care of, her sister said to me, she was doing what she loved. Yeah. And, if you go out doing what you love, I mean, for me, that's kind of ideal.
Yeah. It is interesting. We see the worst of the worst cases, and, we see them all the time. So it may seem to us like, it's an inevitable thing that will happen, because of like a high risk, environment if you decide to, but that's not really the case. I think that's like an important thing to remember, working in the hospital and like seeing your patient. I remember I thought that I had a brain tumor when I was working in neurosurgery. I thought I had a blood clot because I was getting like headaches all the time, and I really just needed glasses. But I like was so convinced, when I was like 21, 22, that I had a blood clot. I'd like been on birth control, and, I had seen, my patients that I see all the time were neurosurgical patients with brain tumors and blood clots. And,
it's that mindset. Yeah.
Right.
You're it's like, wait,
no, I just am dehydrated and I haven't had my eyes checked in years.
Yep. Yeah, totally.
Just run of the mill. So,
that was like, when I worked in orthopedics, I ended up hurting my back. I ended up herniating a disc in my lumbar spine. And again, as a nurse, the second it happened, I went, oh no, something bad happened. And everybody was like, no, it's going to be fine. My colleagues, because I got hurt at work, and my colleagues were like, no, you're going to be fine. It's just, you're just sore. It'll go away. And then I went to my primary, and he said, you're young, it'll go away. And then it didn't go away. And I went and got an MRI and got a phone call saying that I had a pretty severe herniation that was likely going to need surgical intervention. And so, and it was, the second it happened, I was like, I'm hurt. This is not good. And never would I have expected it to go all the way to surgery. It kind of went from 0 to 100 pretty quickly. But I think nurses in general are very intuitive, and that includes our own self-awareness. Like you said, obviously you didn't have a tumor or a blood clot, but we are hyper aware of not only patients' clinical changes, but our own medical clinical changes. And nurses really are the worst patients, because we think we are either, no, it's nothing and it'll be fine, or it's maybe I am really hurt. Maybe I should get this checked out. So
I know I ride that line all the time. I'm like, I'm probably fine.
Let me eat something and drink some water, and if it doesn't go away, I'll take some Tylenol, and if it doesn't go away after that, nah.
Right. Like, I'm going into work, I might as well just stop at 8.
I'll just swing through.
Yeah, right. I want to talk about Tele-ICU.
Oh, sure.
So that's a really unique thing. I had never heard of that before you were talking about it. So tell me a little bit about what it is and what your role in it is.
Yeah. So, well, I think with COVID, obviously we know that telehealth really picked up during the last few years. And so when I first started in the ICU, we were kind of rolling this program out called Tele ICU. And it was pitched to me in a way that as a critical care nurse at an academic institution, you support rural ICUs and critical access hospitals, and you help them manage their really sick patients. And the goal is to ultimately keep people closer to home. So in Vermont and New Hampshire, we are very rural. So a lot of, I think our closest rural hospital is maybe 40 minutes away. The farthest is maybe 2.5 hours away. And we were transporting these people at the drop of a hat. If they started to look even a little bit too sick, they said, "Nah, we got to transfer them. We got to transfer them. We got to send them out." And so we, as a program, are working really hard to keep those patients close to home. We find that if their family is involved, their outcomes are better. And when you have folks that are in a hospital 2.5 hours away from home, their family can't come and visit every day.
Yeah.
Their family can't be involved at the bedside. Driving, and all that drives care too. So that makes managing that care really challenging. So I monitor 4 rural ICUs between Vermont and New Hampshire. I have a census, and I also monitor the 60 ICU beds that we have in-house. So I monitor anywhere upwards of 90 to 100 ICU patients a night. They are not all intubated, they're not all sedated, but they are all in an ICU for one reason or another. And so we help those hospitals manage their ventilators. If they do have a patient that decompensates, we assist with rapid sequence intubation. We help assist putting in chest tubes. Our program, our tele-ICU program, helped prone the first COVID patient in the state of Vermont. So we helped hospitals implement paralytic protocols and proning protocols for COVID. And we provide a lot of these hospitals with intensivists. So some of these hospitals, they only have a hospitalist overnight. And as great as they are and as smart as those hospitalists are, they really do need the support of an intensivist.
Yeah.
And so we do provide that for them, which is great. I find that there's a varying degree of excitement when it comes to having our involvement. A lot of these small hospitals, like we've been managing on our own this long. What do we need Big Brother for? And it's like, well, the reality, and I've had this conversation with bedside nursing, the reality is we don't have beds. Tertiary care across the tri-state area for us has been, the bed availability has been very limited. And so, sometimes you have to be frank with these bedside nurses that are like, well, they're getting too sick. We're going to have to transfer them. And it's like, I'm sorry to tell you, there's nowhere for this patient to go. So together, we're going to work together to manage this person. And I'm going to give you, we write orders for these nurses and for these patients. We monitor all of their lab work. We have their cardiac telemetry up on our monitors all the time. So we can identify hypotension and rhythm changes. Like for example, I caught a STEMI at one of our hospitals one night, and it was just a little change in their. And for me, we know our monitors are not primary monitors, but I always call the primary nurse and say, "Hey, is this patient experiencing chest pain?" Or I've noticed that their telemetry is looking a little different, and I think it may be worth working it up.
Yeah.
And sure enough, did an EKG. The guy was having a STEMI.
So you have access to like their EMRs?
I have access to all of their EMRs.
Okay.
I cannot document in all of them. So there are some cases like for the hospital I work in, we also monitor our own ICU beds. And so I'll say to my colleagues, hey, while you're getting settled, can I put vital signs in for you? Can I throw a weight in for you? Can I document their neuro exam for you? And so I find that that can be very helpful. With the outside hospitals, if we do a rapid sequence intubation or a code, I will record for them. So I'll record and then I'll either type it out or write it out and I fax it over to them so that they have that as a record of kind of what they did in the room. And that way it allows,
So go ahead.
No, I was just going to say that allows the primary bedside nurse to really focus on the meds that they're giving, their patient condition, and then that allows us to really take all of that off of their plate, you know, because then at the end of the night, I mean, and how many times have you sat down to go chart and you're like, what just happened?
So many times. Absolutely.
Totally. Yeah. What in RSI and in high volume resuscitation, you're like, how many units of FFP did we give? And so having somebody, and I always say, just yell it out. Just yell it out. I will write it down. You know, we do a closed loop. They say epi given, epi given, and I write down the time. And it's just, it's nice. I find that a lot of the small hospitals will really appreciate, especially in situations like that, our input and our involvement.
What is the audio video setup in that circumstance?
Sure. Yeah. We have, so in every ICU room, we have hardwired audio visual equipment. So you have a camera and a monitor in the room. So we can kind of chat just like you and I are now. I can engage my camera and then I can engage my camera looking back at me so that they can see me. So I can do my own assessment sometimes, you know, how you feeling in there? You know, you look a little tired. How's your breathing feeling? And then I can report to the bedside, you know, if the bedside's busy, I can sit with, you know, I've caught people trying to climb out of bed before and I've turned my camera on to be like, hey, you really need to get back into bed, please. You know, and they're always like,
what? Where is that coming from?
God. You know, so, so we have a lot of capability, and the quality is excellent. I mean, so it's usually, if you think about your ICU room, our camera is up above, kind of facing the foot of the bed so that you can see directly onto the patient.
Okay.
And you can move the camera around and I can zoom in on pumps. I can zoom in on their oxygen setting on the wall. I can zoom in all the way onto their monitor and I can look at their telemetry at the bedside. I can look at their vent settings on the ventilator. You know, I can look at wounds. I can look at, the zoom and the quality of our video is really awesome.
That is incredible. And you're doing that for, like, you have access to like almost 100 patients.
Yeah. Yep.
That is wild. What a great that's amazing. I wish we would have been talking about that more because I feel we're like kind of wrapping up now. We could have a whole like another podcast about tele-ICU.
Yeah, I mean, it really is. I really do feel like it's the future of medicine. I don't think we will ever eliminate bedside nursing. Much to our chagrin, I don't think we will ever eliminate bedside nursing. But how do we better support bedside? And telehealth has really been the way. And so we're very hopeful that our program is going to expand and grow, and that we can support more patients and our reach is farther, which will be great. And, we only hope to improve outcomes. That's really all we hope to do. Yeah.
Well, it sounds like, I mean, they would be in a much worse spot if it wasn't for this program.
Yeah. And sometimes, yeah. I mean, we've had some really good saves, and It's a lot about education too.
Mm-hmm.
You know, these small hospitals, when they get somebody who's really sick, they don't know what they don't know.
Right.
You know, you and I see incredibly sick people all the time.
Mm-hmm.
And so when these small hospitals get somebody who is just crashing, they're sometimes like, what do we do?
Yeah.
You know, the limits on their medications is different. Like a lot of hospitals, their levo max limit is very low. And so, you know, they have a patient that's crashing and they're like, we can't turn our levo up that high. And it's like, oh yeah, you can.
Yeah, you can.
Oh yeah, you can. Please do that.
Yeah.
So that's a challenge, you know, working with 4 different hospitals, learning their policies.
Yeah.
Learning their protocols, learning what they can and cannot do. Because for us, we're like, give them whatever, do whatever. Yeah,
right.
We do that all the time. And they're like,
yeah,
and they're like, oh no, we don't do that here.
Yeah. Well,
You're
you
like,
don't do
ooh.
that because, well, I'm sure their policies will change the, you know, more abilities they have to take care of sicker patients. You know, it will start to mirror like what you'll do at a trauma one for certain circumstances, you know.
Yep. So, and our telehealth program is really large. It's not just tele-ICU. We have tele-ICN and tele-pharmacy and tele-neurology and tele-ED, and that is also expanding. So truly telehealth is, and I kind of got into it at the right time because I really do feel like it is the future of nursing and of medicine. So it's exciting to see kind of where we're going.
So cool. I would love to have you on again to talk about just strictly tele-ICU. We could have a whole hour conversation about it.
Yeah.
Well, Liz, I'm going to wrap it up here, but thank you so much for coming on. It's always nice to talk to another ICU nurse and, you know, shoot the breeze.
Yeah. I mean, we could talk all day.
Yeah.
Stories. I mean, and that's what's great about nursing is we always have stories, and it's that, I think it's really that shared experience that kind of brings us all together, especially in the ICU. You know, when we see those really sick patients, when we lose a patient, that shared experience is really special.
Yeah, absolutely. Well, thank you so much, Liz. I'll talk to you soon.
All right. Take it easy. Bye.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.